Hi guys, Dr. Gillard here. This is a makeup lecture for week number 2, winter 2018. We missed a lot this week, so you will be responsible for this material. The only difference is instead of sitting in class, you get to sit at home and watch this on YouTube. So here we go. Let's see, we just finished talking about GERD, and now we're going to talk about some other diseases of the stomach. And the first one is eosinophilic esophagitis. So here we go. Maybe we're not going anywhere. Let's see. There we go. So, some AKAs, allergic esophagitis. I'd really like that one because it is kind of an allergy type of a thing, we believe. But those are the AKAs. I'll call it eosinophilic esophagitis, though, for testing purposes. It's chronic immune antigen mediated esophageal disease, and it can mimic the symptoms of GERD. It's also considered a chronic antigen, or what causes it. It's a chronic immune slash antigen mediated esophageal disease. So it's like an inflammatory disease. It's T cell mediated, and there may be a mix of IgE and T cell mediation in there, but don't need to worry about that. I apologize in advance too. We have a full house today. This is grandma babysitting all the grandchildren today, so you may hear some wild screams. We have, 5, 6 of them over today. 6 out of 9, lots of grandkids. So apologize in advance. It seems only to occur. So you have to have some type of genetic susceptibility to this condition. Everybody doesn't get it. In fact, it's pretty rare, as we'll see when we get to epidemiology. And if you take a sample, you go and endoscopically take a sample, you will find inflammatory cells, but you'll find an abnormally large number of eosinophils, which gave it the name eosinophilic esophagitis, caused by an abnormal immunologic response to specific antigens. So in other words, there's something that's triggering the body to attack it. The mechanisms for this immunological attack seems to be that of delayed hypersensitivity, which, as we will see, is going to cause trouble in making the diagnosis. Most of the time, the problem is thought to be secondary to some type of food allergen. So if some type of food that you're eating, one of the proteins in there is binding to the stomach and your body's attacking it, and you're getting the esophagus, you're getting inflammation of the esophagus. Some research says there may be an environmental component in addition to the food allergies, but still the number one culprit. And the way you test it is by looking for food allergens. Most common culprits, here they are, a list of important stuff. Milk, soy, eggs, wheat, nuts, fish, and shellfish are the number one culprits. Making the diagnosis, because this is a T cell mediated disease, you would think you'd do a skin prick test, but actually sensitivity and specificity is very low for that. So there's one called the APT test, where you actually place one antigen on the skin and you have to wait for several days and then see what the reaction is. So the APT test is more accurate than the old skin prick test. And if you can't find an antigen, what if all this testing is normal? Then there's this pretty nasty way to, and this is for severe problems, right? But if you're down, you have to figure it out. The way you do it is you basically stop eating everything, and you go on this amino acid and this special fluid that is put in through a nasal gastric feeding tube, and you have to walk around with that. Basically, you don't eat; you're just fed by a tube. And hopefully if the symptoms should go away, if this really is eosinophilic esophagitis, which we can just call EE if you want. Then you slowly start to introduce foods one at a time, maybe carbohydrates, maybe some breads first, maybe some wheats. And the trick is that you have to wait for a long time because of this delayed hypersensitivity reaction. It can take a very long time for the effect to show up. So if you have like some wheat bread today and tomorrow you feel good, you don't introduce something the next day. You have to wait for days, even weeks in some cases. That's because there's a very long delay in this inflammation manifesting itself. Very frustrating for the patients, obviously. And the prevalence has been on the rise, and it's possibly because more gastroenterologists and are becoming aware of it. The current prevalence is about 0.1%. That's still a big chunk of people, but still fairly rare. In a more recent study of a aerodigestive clinic, which is a clinic that specializes in esophageal disorders and respiratory disorders, the prevalence was way over 0.1%. It was 3% of all the people who came in there, so it's probably higher than what it actually states. It typically affects males more than females, 3-to-1 ratio, and it likes people about your age and even younger, not people my age. Signs and symptoms, it presents like GERD, so it can be quite it can really fool people. So the classic signs of GERD are dysphagia, as we already talked about, odinophagia, that's pain. Remember, dysphagia is more of a discomfort, not real pain. Odinophagia is a real pain with swallowing. Dysphagia is just trouble swallowing. Heartburns, a burning in the base of the throat or down by the epigastric region or in the chest. Regurgitation is the burping up. It's not, and we have slides in this later, but regurgitation is not the same as vomiting. You know that, right? Vomiting is throwing up gastric contents. Regurgitation is just kind of throwing up stuff that's already in your esophagus that maybe hasn't went all the way down. Does not respond. So one way you can tell it apart, it does not respond to proton pump inhibitors. Get that started away. So that's another way you can kind of check it. If it is GERD responds incredibly well to PPIs like Protonix. And if you go have mammometry testing, that's where they stick that wire down you with a little pH thing. They actually have a new thing that they can clip at the bottom of the bottom of the esophagus, the abdominal portion of the esophagus, and it can kind of monitor the acid, so you don't have this wire thing is starting to phase out, but it's still hasn't made it into the literature yet. But you get the pH. The pH shouldn't be super acidic inside the esophagus, right? If it is, then you have GERD. So if you go through mammometry with pH or pH mammometry, and it is low, you have acid, then you don't have EE. Then you probably have GERD. But if it's normal, then diagnosis starts to swing toward eosinophilic esophagitis. And you can have other symptoms. So you can have vomiting, nausea, this globus, like feeling something stuck in your throat. Water brash, what's that? That if you don't know that one, add that to your vocabulary list. That's kind of a regurgitation or coughing up mucus, just tons of mucus mixed with a little acid, and you don't have to cough it up. You can swallow it too, but it comes up into the distal part of the pharynx, the laryngopharynx region, and you can have epigastric pain. Okay, now let's see, boys. There we go. Definitions I just said: vomiting, everything I said, regurgitation, water brash. So official side, not many stars this first quarter I've ever taught this, right? So but there's one, so that's a good test question. And let's see, EE versus atopy. So one strong risk factor for EE is either you having atopy or somebody in your family being atopic. So what is atopy? That's another one for your vocabulist if you don't know. That's someone who's allergic to everything. They're allergic to springtime, hay fever. They have spring fever. They are allergic to peanuts, allergic to shell nuts. They're just allergic. They have dermatitis. They have all sorts of things. That's being atopic. So people who are atopic, in fact, 50% of the patients who have EE have at least one concomitant allergy, like asthma, eczema, rhinitis, like a drippy nose. 50% of patients have at least one parent with history of allergy. So allergy is a big part of this condition. Let's see here, special studies, diagnosis, endoscopically. If you go in there, there's some presentations. If you go down with an endoscope, I'm not going to show you a normal one. We showed you a couple of those already. But one thing that makes the diagnosis is these concentric rings, or they're called linear fissures. Or in addition to these weird rings, I'll show you a picture of those in a second. You can have fissuring too, but concentric rings, and you can have white plaques built up, which are filled with eosinophils. If radiographic finding, maybe you probably won't do a barium enema, obviously, or you won't, or barium swallow. But radiographic findings, boards, because you're responsible for radiology, you'll see this. The classic feline esophagus. You can see these concentric rings even on a barium swallow. And a tapered esophagus is another one you can see. Okay, the responses are thought to be secondary to a full thickness esophageal wall inflammation. Take a look here. So here's the concentric rings of endoscopic view. That looks weird, doesn't it? But this is classic eosinophilic esophagitis. Here's a barium swallow. And no, this is not a barium swallow. This is just, I think it's an old barium swallow. There's still some residual left in it. You don't see all the swallow, but it's still lit up. But you can see the rings. So this is the feline. This is the feline esophagus. Let's bold that. Put one of my favorite colors on that one for next quarter. Feline esophagus of a patient with EE. Okay, here's the tapered esophagus. I've been known to stick these on the test, so but that's right, I don't have any stars yet, so you don't know. But I've been known to throw some of these on. So esophagus, this is a complete barium. It's filled up with barium here, which makes it look very radio opaque. And see how it narrows and narrows and narrows and narrows. So that's a tapered esophagus. So biopsy of the esophagus via the upper endoscopy makes the diagnosis, and again, there's just tons of eosinophils in the sample. It's not easy to make this diagnosis because now new research is showing that some people with GERD, the irritation of the esophagus, is actually causing increased eosinophils on biopsy. So now you have to be careful with this. And recently, this is 2016, a type of eosinophilic esophagitis has been found that actually responds to proton pump inhibitors. One of the big tricks to make this diagnosis is proton pump inhibitors don't work on it. But now this is very new research, hasn't made it into the textbooks, definitely won't be on boards. But there has been a specific strain of this that's responded to proton pump inhibitors, so not as easy as it used to be. Tough diagnosis sometime. What do you do for this? You can give the patients corticosteroids either orally or you can put them, nebulize them, aerosolize them so they can breathe them in. It's very good at calming down the inflammation, cutting down the symptoms. However, if you don't do allergy testing, you don't find out what the cause is, it's going to come back in 90% of people. And if you research bias, it's probably like 98% of the people if you take the research bias factor or the publication bias into the account. Okay, you should also, it's recommended that the patient be referred to an allergy specialist as well. Alright, so instead of making gigantic YouTube videos, let's cut it off here and we'll do this by section. So the next one up will be a Mallory Weiss tear. So see you on that one. Let's hope this one worked.